everybody in here in just a minute. So let me go ahead and do that. Okay. So welcome everybody. I'm Roseanne Bump with FEI Twin Cities. It's great to see everybody here this morning. So welcome. We've got a great program lined up for you this morning. We've got Marsh McLennan here with us today. And we're going to jump right in. So I'm going to turn it over to PK Kriya. So PK, do you want to introduce yourself and take it away?
Sure. Thanks, Roseanne, and welcome everyone. My name is PK Kriya. I work for MMA on the Employee Benefits Consulting team. And it's my honor and privilege to introduce Sarah Delaney, a dear friend and colleague. She is our Vice President of Analytics and located in Sioux Falls, South Dakota. She's fortunate to be at her office today, sending us all good vibes. And she's been with MMA for 4.5 years. Thanks, Sarah.
Yeah, absolutely. Thanks, PK. Thanks everyone for letting me join your meeting. I'm kind of excited to share some of the thought process that we've gone through. You'll hear some of my opinions. As PK knows, I'm not short of any of those. So just talking through, what impact is this going to have for you as financial leaders, and how do we actually start looking forward to the future rather than this crazy chaos that we're living in right now, and how do we plan for some of those pieces? So like Roseanne said, please do not hesitate to interrupt either via the chat or just verbally say, hey, Sarah, I don't like that, I don't agree, or I want to hear something different, or can you explain a little further? As interactive as you guys would like it to be. I put together slides that I have some information, but please don't hesitate to ask any questions. So with that, I will start sharing my screen. Let's make sure that everyone can see it now. And actually, just one second, I'm going to move it to my other screen so that it's bigger here for myself. Sorry, just one second. Okay, can everyone see now?
Yes.
Okay, wonderful. So let's talk a couple of things. We'll talk about data. If any of you do or do not know, my background is I'm actually an actuary by trade. So I am completely a numbers geek as well. My role was the Director of Underwriting and Analytics for a health plan prior to coming to MMA. So working with CFOs, CEOs, and really identifying either from a small group, a large group, a fully insured, a self-insured side, how do we actually look at data and interpret it, I think is a really important piece. We'll talk a little bit about testing and treatment. The short-term and long-term implications, I think, are probably going to be where we're going to focus a little more of our efforts, more so than just the cost of treatment and testing and the actual virus itself. How are we actually reacting to it, and what do we anticipate that impact is going to be on our health insurance benefits? And then we'll talk a little bit about our cost calculator and some things that you should be thinking about and how we're actually viewing the financial side of it. And then I'll leave some time for questions if you didn't want to actually speak through them during the presentation. So first, what are we hearing? What is the financial impact actually going to be? What are my claims costs going to be? It's a little bit about what's happening right now during the shutdown. And the reality is even though we are in neighboring states, the reality of South Dakota versus Minnesota, versus Wisconsin, every one of them is completely different in how things are reacting and how it's actually going to impact the local marketplace. So talking through, what the impact of Minnesota specifically is going to be is an important thing of what we'll discuss. Just some of the layoffs and furloughs. So we had some very short-term furloughs that were happening during, the initial shutdown. What is it going to look like when a second wave comes? Are we going to shut down economically like we did before? How are we actually going to adapt to some of those pieces and really be able to understand and then ultimately make sure that we're projecting our costs appropriately? So whether you're fully insured, making sure that we're helping to actually work with the carriers to essentially hold them accountable for the expected costs. How is it going to impact the provider, and what does this whole funnel of the cost impact actually look like? So let's just talk about finance leaders. PricewaterhouseCoopers actually put together a really good survey initially that was, what are financial leaders actually talking about? Obviously, the recession has been a big piece of things. I can't imagine that every one of you that's sitting in one of these chairs on the leadership teams are not focusing somewhat in how this is a shift in your business. And so not only is it a cash flow issue and a financial issue for your business, but really figuring out how that actually impacts all pieces of your business. Then looking at what impact is the workforce reduction and productivity going to have. 41% of them were concerned about that, and then understanding obviously just the liquidity issues. So watching your facts. This is probably one of the most important things that I tell people. I can be very honest from any analyst standpoint. It's very easy to make data say what you would like it to say. And so it's important to understand how the data you're actually viewing is to be interpreted. And I think that's the problem. I don't know if any of you have decided to potentially turn off the mainstream media in the last couple of months. Just the reality of what we're seeing is very political in nature. It doesn't matter which side you stand on. You can clearly identify opening CNN every morning. I look at CNN and then I look at Fox News immediately. So looking at the two opposites, and then obviously trying to find some of those more neutral sources to really find some of that true credible data. And so I think that's one of the biggest pieces. Is the source national, regional, or local? And I think that's probably one of the pieces that has been the most difficult to focus on, is that we have, can somebody actually, I think there's a little bit of background noise, if we can mute our lines, thank you. Is the source actually visible to your population? Is it something that you need to be addressing? The reality is that in the upper Midwest, things might be a little heated. I actually just saw a post saying that travelers from Iowa to Illinois are going to have to quarantine or potentially have fines or penalties. And so that's somewhat new, but the reality of how Minnesota and South Dakota react, or Minnesota and North Dakota, or even Minnesota and Iowa might be different. What we were initially seeing in New York and New Jersey is not the same as what we're seeing in the Midwest. So really being able to understand and determine what impact some of those are going to have, I think, is important. The reality is the data is fluid. The instant you pull information, it is irrelevant. And I think that's one of the hardest pieces about dealing with this pandemic, is that no one really knows what's happening and how can we actually adjust. The other piece is just in general, are you fully insured or self-insured? Just knowing those that are fully insured from a client perspective, it's a little bit more about really understanding how your carrier is going to react and how your broker partner specifically can help you to hold them accountable. On the self-funded side, you have a whole lot more from a cash flow perspective that you need to be addressing and making sure. So really understanding, how that data is actually pertaining to you. So watching your facts. The reality is all models are wrong, but some are useful. Some of those that are on our team, or any of you that have ever dealt with me, a lot of times, we as actuaries will put together information, and the reality is that if I'm actually right, it's somewhat of a luck and a chance. Our goal is to be directionally in the right aspect, and so understanding that all models are wrong. They're truly just that. They're models. And you have seen several of the, even Johns Hopkins models, some of the CDC models. This is actually, I think it's 20 some of the actual models that are the prominent models. And you can see just the variability from the CDC's website. I pulled this one just the other day based on the expectation of the cumulative reported deaths. And you can see that they vary pretty significantly over each different time period and each model. So just understanding that there really is no good data. No matter what you're looking at, it's probably not right. And how do we actually address what we need to understand? So understanding your geography, your demographics, your mortality and hospitalization rates. So I think that's really important. And I remember Governor Walz actually saying initially what impact that actually was having when we were talking about the long-term care. And so in Minnesota specifically, because I do think right now, as of yesterday, there were 1,510 deaths in Minnesota. Of those, 1,100 and 75 have actually been in long-term care or assisted living facilities. So it is a little bit of a skewed result. Obviously, we're dealing with those that are somewhat confined and unlikely to be part of your population and your employment population, and also unlikely to be part of the insured population. Most of them are either on Medicare or Medicaid and are unlikely to be part of the commercial marketplace. So what impact is that actually going to have? How are we going to see that? And so I think just understanding where the numbers actually are and how that can be skewed. I put together this, this chart here in the middle because I think it's very important to understand that raw numbers are really difficult to interpret sometimes. So if you look at the green boxes or the green bars are the total number of cases per million population. And that is for the states. I did the six highest states and then the surrounding states for Minnesota and what that actually looks like. And you can really see that New York, New Jersey, Illinois have a much higher prevalence than primarily those in the Midwest and the upper Midwest. You can see that Iowa and South Dakota have been hit primarily by a handful of pork producers, and you can see that that has actually bumped their numbers up. But the reality is now when you look at the line, that's the actual death per million population. So once again, you can see New York and New Jersey are significantly higher, but once you get down to really primarily the rest of the states, the actual death rate is significantly lower. So being able to actually take some of those raw numbers, I think the scare tactics of the news, my husband and I had actually stopped. I have a 7-year-old at home that we used to watch, that first 90 seconds of the news a lot of times where they would kind of give you that very quick recap of the news. And I challenge you to even watch the news. It doesn't matter which channel you're watching, but the mainstream news, the first 90 seconds of what you're hearing are very extreme words. They're intended to get you coming back over and over again. So dire situations that they're using, broad words that are intended to keep you coming back and consuming more news. So just making sure that you're able to view the data in every aspect that you possibly can, but in a neutral position so that you can really digest some of the pieces. What we know today. So most states have begun reopening in some capacity. We know that some are starting to close back down. There's kind of a gamut and a mix of what's happening. Most of them are deciding, are schools going back in the next month or two and what that's looking like. The World Health Organization, while the United States is in the process of decoupling their relationship with the World Health Organization, they are still reviewing the evidence of antibody responses to COVID-19 and what potential immunity they have. And part of what the actual evidence is showing right now is that antibodies actually don't live in your system at nearly as long as we had initially thought. And so right now I've heard anywhere from maybe 4 weeks to 2 months, maybe 3 months. And so understanding that even if you had it, back in potentially January or February, my husband is an airline pilot. The likelihood that he was flying individuals back and forth from China, and he actually was very sick in February, he potentially could have had it, but it's very unlikely that he has any of the antibodies left in his system at this point in time. So understanding, that the antibody testing is somewhat unknown, and we are learning. Even if you think about the flu vaccine, that flu vaccine is updated every year, and pretty much every year it's wrong, where there's only a handful of the viruses, the mutations of the virus that they can actually modify within the vaccine each year. And how do they review that? Is this vaccine going to work for any mutations of the virus, and working through that? So it's just a very difficult process, somewhat. In a lot of cases, some of these vaccines are 30 years in the making, so we're fast forwarding some things very quickly. I think that the primary view of what's going to happen with a potential resurgence in the fall is not likely to be a shutdown in a complete shutdown fashion as we were earlier in the spring. I think the economic fallout nationally was something that I don't know, even in the most democratic states, I highly anticipate that there won't be a full shutdown as we move forward. And just one second, you guys, my other conference line is ringing over here. Go figure. Okay, sorry about that, guys. So understanding that that likely shutdown is not going to happen. And so what are we actually going to see? I just saw that the CDC came out yesterday indicating that they anticipate that the fall and winter will be the worst season we've ever seen when it comes to influenza and COVID. Is that reality? Is it not? I think we all know that no one really knows what's going to happen. So understanding that it's likely going to be some shift in services and shift in costs, but probably not a complete shutdown just due to the economic impact. So understanding some of those. Right now, there are several current clinical trials for therapeutics that are actually happening. I want to say it's well over 50 of them within the United States in several different phases. Globally, there are 4 different therapeutics that have been approved. As any of you have seen, there have been several potential hydroxychloroquine was one of them where they started the trials, they paused the trials, they realized that potentially it has more symptoms and side effects than the actual benefit of it, but then it has had a resurgence in interest in the last couple of weeks. So really understanding the remdesivir, there's several different therapeutics that are currently being tested. The vaccine is likely this fall. Yesterday, Moderna Health actually moved an announcement that they were in phase 1 of the first human trial for a vaccine. So I think it was 48 individuals that they started that trial with on July 27th. They will be moving that to phase 3, and that will include 30,000 people in hotspots to determine what that will look like, and that trial should be completed in October. The reality is, even with this Operation Warp Speed, so as part of the CARES Act, Operation Warp Speed identified that there would be some significant funding for any of these vaccines, but the reality is they still have to be mass produced and then disseminated. And the way that even the flu vaccine works, I'm sure that many of you have had issues potentially with even getting into the service and understanding, you know, just the flow of the actual vaccine will be pretty interesting. What we can see though is that there are 135 at least vaccines that are actually in the preclinical trial. 15 of them were in phase 15 of them were in phase 1. One of those being the Moderna, which has moved forward now to July 27th, being in phase 3. So there will now be 5 in the large scale tests within humans, and then hopefully having 1 for use as we move forward. So testing. As almost all of you, I'm assuming know, testing as part of the CARES Act was required at 100%. So no cost sharing to the employee for testing for fully insured and self-insured plans. The reality of that is that the testing itself is relatively inexpensive. So non-CDC labs, which is where the majority of them are actually happening, so in most of the hospital and clinical settings, the test based on how the providers are actually contracting is somewhere between $75 and $100. And then in that case, a lot of them, we're not seeing the drive-through testing sites where we were seeing before. So we're most likely seeing a telehealth visit or an office visit or potentially an ER visit. So just depending on it, these are costing somewhere between $100 and $1,200 should that person actually present in the ER. What we're actually anticipating though, and what we're seeing is that this is a less than a 1% additional spend. So the actual cost of testing has not been significant. I don't think it's something you should be concerned about within your plan, whether you are fully insured or self-insured. But I do think it's good to know there were codes that actually had to be applied. CMS had to identify new codes for testing that were never there. So it was kind of a fast track of things that usually take several months. It took a couple of days. The actual treatment, it really is going to depend on who you are as an employer. If you are an employer within, you know, a hot spot potentially, you know, for example, here in Sioux Falls, we had a pork processing plant that's actually only 5 blocks away from our office here. And that pork processing plant had almost 1,000 cases. They were people that live in communal locations. So not only were they in very tight quarters within their working spaces, they all lived within, 20 people in a home. And so that was very quick that it ran through, and the prevalence rate was increased pretty significantly. The reality is, though, they were generally the younger 20 to 40 somethings that were primarily healthy. So the hospitalization rate and the severity rate was significantly lower. For the potential of one where maybe you actually work in an office setting where maybe it is tighter quarters and your population is an aging population, you might see a higher prevalence of severity and critical cases. So this is actually something that the Society of Actuaries put together. I'm not going to go through all of the pieces, but this is looking at how many people are anticipated to actually be asymptomatic, mild, or moderate. So having, general flu-like symptoms. We're still talking about 60 to 70% of the people actually having very minimal situations. And we're really only talking about, from a critical aspect, 2 to 5%. And we'll talk a little bit about what that looks like from a Minnesota aspect. Once again, primarily the different age cohorts, we're still looking at for the mortality rate to be significantly higher, as in Minnesota, for those that are 60 plus, indicative of just the long-term care facilities and or assisted living facilities. You guys, I have a conference phone that is literally all the way across my desk here and it keeps ringing. Go figure. So COVID treatment testing, I'm gonna have to unplug it. Here. All right, that's what happens when you get back into the office, when people are trying to just randomly dial phone numbers, I guess. I'm completely apologizing here, you guys. So looking at the actual cost of treatment, in each one of the different treatment scenarios, the Society of Actuaries has actually put together several different aspects, looking at what the actual testing looks like. I don't want to go through all of these numbers because I think they might bore you. But the reality is even in that critical case, we're talking about a $240,000 claim. So depending on the size of your group, these are somewhat normal claims. They're probably not going to break the bank completely. And the likelihood of you having multiples, depending on how large you are, is still relatively low, primarily depending on your population. So just understanding if you're in a small manufacturing side of things, and the way that PPE is being used, so social distancing is being used, will obviously impact some of the cost structure for treatment. So treatment costs obviously are going to depend upon the demographics and the geography. Most fully insured plans have decided to cover that treatment. We're seeing that a lot of them are extending through the end of August. I fully anticipate that will continue to expand through the end of the calendar year, and then reviewing what that looks like moving forward. Most self-funded plans have had the opportunity to determine how they are going to actually provide that coverage. So understanding that it is not a guarantee either way. We expect the cost in 2020, just based on where your plans stand, to be somewhere between 0 and 10% in cost. And this primarily has to do, and we'll talk a little about our cost calculator, primarily has to do with, one, just the demographics and the geography of your population, but then understanding the cash flow and how that works. So I'm anticipating that in this calendar year, we're actually probably going to see a decrease, but then in the next calendar year, when we're talking about 2021, when things start to ramp back up again, that we'll see an increase. The Minnesota hospitalization rate is 10% of those that have tested positive. Of those, 3.5% have died. So it still is a pretty small number as we're going through this, understanding that the actual test rate is increasing as we continue. Right now, we're talking about 10 to 15 years normally to develop a vaccine that they're anticipating will likely be rolled out towards the end of October. So pretty significant. We're talking about antivirals and immunotherapies. The reality is that a majority of these are going to be very low cost. Many of them are already being utilized today and are not a significant cost. So, we're talking about high cost pharmacy drugs and some of these new biosimilars that are happening, where we have a handful of $2 million+ drugs that really are cures. That is not the case from a high cost aspect with a majority of these therapies. The reality is if we're going to be going to be consuming these as a mass population, it's unfeasible for it to financially work at any of those high cost drugs. So we'll see some relatively low cost options that will happen. So those are just the testing and treatment. What I think you should take from those first handful of slides is that I fully anticipate that we will not have a significant impact in costs due to COVID on the health insurance side. If anything, we're likely going to see a decrease in overall costs. So the short-term implications, initially individuals were changing their fill patterns for pharmacy. So they may have been going to the local pharmacy where they were getting a 30-day prescription, whereas now they might be getting a 90-day prescription, potentially from a mail order aspect, so they don't have to leave their home, or maybe the CVS pharmacy within Target isn't open the same hours that they're looking for. So understanding that there may be some changes in utilization patterns. Increase in telehealth. This has been one I think that has been a positive. We've been talking about telehealth in a lot of aspects for the last several years. There's been a very, very low utilization rate for those services. We have seen significant spikes. I just saw something the other day that was indicating that nationally it's an 8,000% increase in telehealth visits. So understanding, what impact that's actually going to have longer term. Those are very low cost services in general, somewhere between probably $40 and $80 for most of those telehealth visits. So we're seeing an increase in those, but that's necessarily being offset by just a decrease in the actual in-person office visit. We are seeing an increase in testing for all respiratory illnesses. So not only just COVID-related symptoms, but should anyone have any chest issues, potentially respiratory issues, they're likely going in and they're kind of getting a gamut of tests potentially. So they're getting a COVID test, but they're probably also getting an influenza test, maybe a pneumonia test, maybe they're getting an X-ray that's happening. We're also likely seeing an increase in ER visits for those respiratory symptoms. So the urgent cares and emergent cares are closed, and so they're ending up in the emergency room, which is obviously a significantly higher cost treatment. Then just the obvious, right? Dealing with the actual treatment and testing for COVID, a relatively minor impact, but understanding that it is an increased cost. The cost of therapeutics. So right now we're not seeing a significant cost related to that because there are no mainstream approved therapeutics, but should we see that, we will see an increase in cost. What we are seeing, however, is a decrease in cost that is more than actually overcoming the increased cost from all of the other pieces. So the increased mail order utilization, somewhat minor, but the overall cost to the member and to the plan is generally lower. The reduced cost in routine care. So this is not a good one. People are not seeking routine care. And when we talk about some of the long-term impacts, these are some of the things that we should be thinking of as employers about how to actually manage these. So we'll talk about that a little bit more. People just not getting their diabetic service, not going in for that mammogram, not going in for that colonoscopy because they're afraid to be in the hospital or maybe something was shut down. Cancellation of these elective procedures and specialist visits. I just heard a case the other day of a woman who was diagnosed with cancer and had tested positive for COVID, but had no symptoms. Well, she couldn't actually receive any of her chemotherapy or radiation until she was considered COVID-free, and she is now 6 weeks in to still testing positive, even though she's been asymptomatic. And so, understanding what that actually looks like in those elective procedures, what impact is that going to have long-term on her cancer diagnosis and the treatment? The delay in cancellation of duplicate pre-surgical testing. So there were a lot of tests that actually happened prior to when COVID hit, where individuals had tested for an actual condition, or they had maybe labs prior to their actual surgery. Maybe they had a quick CT scan or an MRI prior to their surgery. And then they might have to actually redo those again prior to the next surgery and the rescheduling. So we'll see some duplication of some of that. Shift in the type of admission. So the admission in general is that we're seeing, very few just general medical and surgical admissions. They're starting to ramp back up again, but that has been quite a reality as we continue. Babies obviously didn't stop, but we're seeing the severity of some of those issues being more significant and having those that were more acute and less severe not actually occurring in a hospital setting. A decrease in urgent care. Obviously, the urgent cares were closed for a very long time, and so we just really didn't see any of that urgent care. It either turned into telehealth or likely didn't happen at all. Dental and routine vision, or excuse me, dental and vision routine claims are one of those that I think are quite interesting. Those that potentially had dental issues, maybe they weren't getting in for their 6-month appointments, and we all know how hard it is to get into a dentist anyway. So, pushing off some of those services for longer, that maybe that filling was just a filling, 3 or 4 months ago, and maybe if we wait a year, maybe we're talking about a root canal, which is a significantly higher cost service and could potentially impact their medical as well. So, short-term decreases in the actual cost, just changes in the fill locations. These are some of those where it might vary. If maybe you were going to the local pharmacy because you loved that pharmacist, but then they actually closed and now you're forced to go to Walmart or you're forced to go to CVS, is there a change in the actual cost based on the availability of where things are open? And then I think this is one where we're seeing now that we're starting to talk about open enrollment for 2021. What ability do you have to actually administer the wellness program? So a lot of the biometric screenings that are happening, all the blood tests that are happening, if it's a physical that's required, how are you actually going to be able to maintain those? So there might be some potential for some decreased services, or, in the event that you're having to provide in-home kits, significantly higher costs. So what you need to do, being a fully insured plan, if from these short-term impacts, be an educated consumer. That is probably the biggest thing that I would say for anyone. Doesn't matter what you're doing, just making sure that you're educated and you're asking the questions as you go through this. We work with our clients and the carriers that what we're doing is we're actually ensuring that we understand what's happening within their marketplace so that we don't allow the carriers to actually overreact to the renewals. So if you listen to the scare tactics that are likely happening in some of the mainstream media, what you'll hear is that, this cost, it's enormous. We're seeing changes in everything. We're going to see costs starting to increase. The reality is that they've been actually able to build up reserves right now. I'm sure that a lot of you received some type of a benefit back from your car insurance company. It's highly unlikely that you're going to receive that back from your health insurance company, but making sure that we can help to hold them accountable for the cash flow that they probably aren't spending in 2020, but will and should be spending in 2021, and make sure that we're not overstating your premiums for 2021. So that's really what we're focusing on with those fully insured. Make sure that your plan documents are up to date and how you're communicating with your employers. Your employees. Making sure that what your plan is actually covering is how you're communicating, and then how your actual documentation of your leave, all of those things are appropriate. Developing your return to work plan. I'm sure that this is something we personally, in all of our MMA offices, I'm really sick of talking about it even, because it is such a process that we're going through, and who would have ever guessed that 6 months ago we would have been in this position. But continuing to modify that and being nimble based on what the prevalence looks like within your community. Staying consistent. I think this is one of the important things, making sure that you're not setting yourself up for any employment issues by having inconsistent responses or promoting leaves differently for specific individuals. Talking about your financial projections, so just your changes in your workforce, understanding if you're going to be shrinking or if you're fortunate enough to be continuing to grow, and in a market, how can you actually anticipate what that's going to have on your renewal, and working through that. And then the big piece is how long is this going to last? How are we going to see changes, and will we see an additional round of subsidies? I'm sure there are several individuals on this call here that were part of the loans that came along with the CARES Act, and understanding what that looks like. Are we going to see increases in that? Are we going to see some changes? Are we going to see changes with unemployment rates, and understanding that? So just looking at it being really an engaged consumer. The self-funded clients, it really isn't all that much different. but understanding that you need to dig into your data. You should really be looking at what your data is telling you. Do you know your demographics of your population? Do you know those that have comorbidities within your population? Do you have an understanding of the likelihood that should you become a hotspot, what is that going to look like? Or just in a general aspect, what do we think the average cost is going to be? So the longer term impact, this is where I think we need to be focusing our efforts from a consultant standpoint, as well as the health insurance carriers. What is this going to do in the long term? Beyond the next 12 to 18 months, what do we need to start thinking about? So obviously we're going to see an increased cost where the preventive services that are required by the Affordable Care Act will likely include a vaccine, should that come along. So we'll see an increased cost, but hopefully that is offset by the need for testing and treatment for COVID as we go forward. The deferred care and treatment for ongoing and chronic conditions. This is probably the biggest cost driver, short of one other that we'll talk about that I'm concerned about as we continue to move forward. That diabetic that didn't actually go in and have their diabetic foot exam, hasn't been monitoring their insulin, and then, like all of us, has been eating a few more donuts in their house than they probably should have, and has put on the quarantine 15 or maybe 45. And so how do we actually understand and manage those populations? So this is where I think employers can be very proactive. How do we engage our employees in staying healthy now, really getting back on track with that care management instead of waiting 6 to 9 months to actually put something in place? Obviously, mental health is going to be a big aspect. So looking at the substance abuse and the mental health claims, my sister is actually a resident in a mental health aspect, and what she's said is that just the amount of individuals that normally had their stuff together have really been those that have fallen apart. They don't have the coping mechanisms. And so how is your EAP integrating? How are you actually managing some of the population? And so really focusing on mental health. It might be more than just your EAP program, the mindfulness aspect of things, understanding where you are and where your population is, I think is incredibly important. And we're not going to likely see this one drop off for quite a long time. We're seeing, obviously, we talked a little bit more about the vision and the dental side of things. We're likely going to see some more major services that will be happening. So is that going to have an impact on dental insurance? Vision insurance isn't technically related to claims in the same aspect, but is the dental insurance marketplace going to see an increase? I do anticipate that longer term we will see more than the 3 to 5% increases that we have been seeing in dental nationally. The decreases in utilization and cost, just the sustained increase in utilization for telehealth services. I'm very hopeful that we see an increase and the sustained increase in telehealth, that there is somewhat of a shift. I think we're seeing more and more go to the actual provider. So a lot of the plans had been using, a doctor's on demand, a teledoc, some of those. We're seeing more of the actual local providers be able to deal with those, and the carriers actually providing the ability for the plans to cover those services within the local provider. So you have the continuity of the medical record that they can utilize. So I'm hopeful that that will see some shifts and some innovation, but we'll obviously have some increased costs, hopefully offset by a decrease in the in-person visits. Are we going to see changes to how people react to illness in the future? So if you're sick, will you just not go will you not go in? Will we see the prevalence of the influenza virus much lower because people just don't go? If you're sick, if your nose is running, or if you have a cough, you won't be in the office. And how does that actually work? Well, we have to impact and change time off. So I think just understanding what impact that's going to have as we move forward is important. Will other vaccine compliance increase? I've seen many memes within the national aspect of, what does this vaccine look like? And, people said you should be wearing masks or you should be getting your flu vaccine for years, but nobody was getting them. Now they say wear masks and individuals are wearing masks. So do we anticipate that all of the other vaccines are going to have a higher rate? Hopefully, yes, that people are starting to understand that they are important and they do provide those immunities. We talked a little bit about the pent-up demand and what that will have on experience. those individuals that didn't have the services, we're probably not going to see all of them happening again. You might have had that knee scope that someone had to have because they injured themselves. They were the 45-year-old male that decided he wanted to still play basketball, fell, hurt his knee, and needed to have a scope. Well, maybe he actually started walking and did some home PT therapy and maybe doesn't need that scope any longer. So we're seeing some shifts in some of those things. Also, just the individual that's scared, their colonoscopy was scheduled and they chose not to actually have their colonoscopy because they were concerned that they did not want to go back into the doctor's office. The next two really, I think, are very important. This is probably going to be, when I say the other largest driver of where the cost lands, is that for a lot of these services, so that long-term care, that skilled nursing, the elderly population is Medicare, and then we're also going to have these services that are for individuals that don't have health insurance. We're going to see those costs shift and the decrease in their revenue for all those outpatient services, because don't joke yourself, the reality is that outpatient services are absolutely where every health system makes their money. So the fact that they had all of these very low cost primary care and urgent care visits, that was not helping anything. They are losing money. Those are loss leaders, and no question. Their primary bread and butter happened to be those services that were canceled. So how are they going to make that up? We are likely going to see some pretty significant increases in charge masters. So a couple of positives, a lot of the larger health plans that you focus on, they have fixed cost arrangements that will happen. So they might have a contract that says, we only pay X for it. I don't care what you charge me, but we're only going to pay $1,100 for that MRI. It doesn't matter what your charge is. And so that's actually probably the best case scenario, that they probably have a 2 or a 3% cost structure built into those contracts. The problem comes with some of those providers where they actually have a discount off of billed. So more of the small TPAs, the boutique TPAs that are providing health insurance or third-party administration, they don't have the discounts where those cost shifts that are happening on the charge master, so what the actual health system charges, is going to funnel down into health insurance costs. So we'll likely see the increases actually occurring probably within the next 18 months, where we had been seeing maybe 2 and 3% cost in the CPI index of the cost of care. It could potentially be 3, 4, and 5%. So where we have seen decreasing trends on medical insurance, I fully anticipate that is going to start increasing. Not only just due to the high cost pharmacy, but now the shift in cost for those losses that are occurring due to COVID and the decreased services. Understanding then too, just the potential shift in production and manufacturing of medical supplies and and pharmacy drugs. I anticipate that we're going to see a lot more happening back in the United States again, just due to the manufacturing issues that had happened. You know, PPE was a really good example. There was such a shortage. We saw a lot of the facilities actually shut down and start producing PPE. I think we'll see more and more happening so that we don't have that flow issue that was happening. And then understanding the unemployment on the benchmark plan. I want to actually talk about this one a little bit. We came off historically low unemployment rates, and we had to, as employers, provide very significant benefits to be able to attract employees. Benefits were an important part, obviously, in addition to pay. But is the benchmark actually going to change? Are you going to have to offer a lesser benefit, or will you have to shift how you're offering benefits? So maybe you don't have to offer the same level of life insurance that you were offering before, or maybe you don't have to offer as competitive of a dental plan, but maybe the expectation is going to be that you're going to have different PTO balances, different sick leaves. Understanding what that looks like, I think, is going to be incredibly important. So this is one of the things that we're going to start focusing on in the next couple of months as we're going through this, understanding what employers actually need to do. What are you going to need to do to be in that top echelon of employers versus what are you going to do to, lead the market, lag the market, be within the market. So I think that is one really important thing that we're going to continue to look for. So that being said, one of the things that MMA has actually put together, I know there are some other sources, but I think one of the cool things that we've actually developed is a tool that takes into consideration all of our pieces that we really feel are the most important. So the demographics, your industry, your location in your geographic area, and then the layoffs and furloughs that you've had, and help you identify what impact that's going to have. So this is kind of just a snapshot of some of the pieces that we just have talked through, you know, those that are increased cost and those that are decreased cost, and what impact that's actually going to have. So we're providing our employers with kind of a range. You know, should we have a significant resurgence, we should, you know, what should you anticipate the expected cost to be in a very low scenario, very high scenario, understanding this year versus next year, and really being able to put some expected dollars to that. But my favorite part about this is a little bit of how we've actually dissected it. So understanding that in this case, this employer had $6.4 million in benefit costs. We are going to see they did some layoffs. They did a handful of furloughs, but they offered 100% coverage for those furloughs. We had a significant reduction in expectation in outpatient services due to the shutdown. But then that was offset by some of the other increased cost aspects. And so being able to understand that for this employer, we really only expected it to cost 1.6% more over the next 2 years than it would have historically. So not really a dramatic increase, but then understanding what the cash flow impact looks like. And so there's two things that are really important about this. On a fully insured aspect, those numbers in the pink generally are causing decreased costs to make sure that we're making sure that the fully insured carrier is being held accountable. For that self-insured employer, I want to make sure that when we're sitting across the table from that controller or that CFO, that they've had some favorable months, but we want to make sure that we don't overreact to that favorable experience and make sure that we're really adapting appropriately and planning for some increased costs as we move through some of the next couple of months. So these are some of the things that we personally are working through and adapting for some of our employers. So really, it is a cyclical, it is a cyclical process. We're continuing to work through monitoring the information. I can't begin to tell you, I have actually done this similar presentation at least 8 times for different offices and for different populations. And I've had to actually redo the actual presentation every single time because the information changes. How we're adapting to it changes every time. So not being complacent and really looking at how things are sitting today, but understanding how we truly feel like it's going to impact the future. So I realize we are coming to time, which we left a handful of minutes, and I have not been watching the chat. So if there have been any questions, you'll have to let me know. I know I filled you with a lot of information. I speak very quickly as well, so.
All right, Sarah, let's hit some of the questions in the chat. Can you respond or see those?
Yes. So let's see here.
And Sarah, I can ask mine. I'm wondering if there will be a rush to the vaccine, or are people going to kind of hang back and let some others take the hit first? So how do you anticipate that being received?
Yeah, so I actually was talking to one of the nurses that's a good friend of mine the other night, and she's actually in charge of a vaccine deployment, and I was actually surprised to hear her response. She said, I'm going to wait and I'm going to let others actually see what this looks like just because it is so new. I, on the other hand, I can tell you that my family will have the vaccine, very quickly. I'm comfortable with that. So I do think we're going to have a general rush for those that want to figure out how to get back to normal. I think we're going to see it in red states very much more than we're going to see it in blue states, just because of the financial impact of things. But I think we're going to have a supply chain issue. The reality is that we're probably not going to have a lot of the vaccine available as fast as we would like. Much like we had with the testing, we're probably going to see that along with the vaccine. Yeah, so someone said of the 1,175 deaths in assisted living, 90% of those had DNRs in place. So I don't want to be the negative aspect here, and I hope that this doesn't offend anyone when I say it, but The reality is no one goes to an assisted living or a long-term care facility to live out their best life. So the reality is I've talked to several nursing home administrators, and we're classifying individuals as having COVID-related symptoms, but should they have had a cold, a flu, a pneumonia, no matter what, they potentially could have passed away as well. So I think we're actually identifying a lot more individuals as having a COVID-related death than they maybe would have as well. So it's really important to digest the data appropriately and make sure you have all the information.
Sarah, there's also a question on the blood type, maybe having a relationship to COVID disease. Do you know anything about that?
Yeah, so a couple of interesting things related to that. So the American Red Cross is actually leading one of the antibody tests. And as crazy it is, my husband and I donated blood last week and had antibody tests. We both came back negative on our antibodies, but they are anticipating, as part of a lot of those studies right now, that they do think that there are some potentials of what blood type you actually have and the impact. But right now, I think it's way too early on from what I've read to actually identify any of them. And then the same thing, if they're not staying in your system long enough to actually do any good, it doesn't matter.
I think you covered them. Bruce, you had the question on the individual getting COVID multiple times. Sarah, you've addressed that.
Yep. We actually have an individual in our office that actually is one of our employees that hasn't been in the office, but was one of the positive cases. And she had it in March, and we are still at the aspect right now where she is still having positive tests. So I think the reality is it might still be in your system, but you might be asymptomatic. And how are we going to deal with that? Bringing employees back to work and dealing with, what that looks like, even in the school settings, right? We've all heard kind of what's happening there. I do think that this is going to be tough. A lot of the school districts, I know Minnesota's working on it right now, but a lot of the school districts in South Dakota have decided they are going back to school. I think the fight over right now is whether masks are going to be required or recommended. But that's just the start of it. How are they going to deal with substitute teachers, right? Or quarantining? I can say that I am so happy I am not on a school board at this point in time. It would be really tough.
Okay, I think we covered it. Roseanne, did you have anything you wanted to close with the CPE? And
Yes, so just a reminder, if you are looking for CPE, go ahead and enter your first and last name in the word CPE, and I will make sure that we get that sent out to you. And then also I'd like to thank Sarah and all of the MMA team for being here and presenting this information. It was very interesting. And Sarah, I appreciate the comment about it ever changing, because it's gotta be a whirlwind keeping up. So, and then I would like to—
please don't hesitate to reach out to any of us too. If you need any help, PK, myself, any of the MMA team, Natalie, all of us on this call, we are more than willing to help answer any of the questions.
Great.
Or provide lots of opinions.
right, we're not shy.
Yeah, I will be sending out the slide deck with contact information just to make it easy for everyone. And then I want to invite everybody to join our next webinar, which is next Wednesday at 11 a.m. And it's going to be Wells Fargo presenting on preparing for the transition from LIBOR. So another interesting topic. So thank you so much, everybody, for being here. Really appreciate it. Have a good day.
Have a nice day.
Bye.